Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's February 2019 issue. There are 4 articles this month that have been selected as our Editor's Choice or Highlights articles. Our Editor's Choice is an original article entitled Menopause Management Knowledge in Postgraduate Family Medicine, Internal Medicine, and Obstetrics and Gynecology Residents, a cross-sectional survey. This study is authored by Dr. Juliana Kling from Mayo Clinic in Scottsdale, Arizona, and colleagues from several institutions in the United States. Menopause occurs in all women living beyond midlife. The number of postmenopausal women in the United States is increasing and expected to exceed 50 million by the year 2020. 75% or more will experience bothersome vasomotor symptoms, which can be quite incapacitating. Both the direct and indirect healthcare costs associated with untreated vasomotor symptoms are estimated at $400 million annually, and inpatient as well as outpatient healthcare costs are high in women with untreated vasomotor symptoms. Because of such considerations and the fact that menopause occurs in all women living beyond midlife, it is important that clinicians responsible for the primary care of women be fully engaged in the management of menopause. Several studies suggest that there may be gaps in training specific to women's health in primary care residency programs in general, and with regard to menopause in particular. The purpose of this study was to evaluate the knowledge and nature of training for menopause management in postgraduate residents. Data were obtained via a cross-sectional anonymous survey emailed to trainees at all postgraduate levels in family medicine, internal medicine, and obstetrics and gynecology at U.S. residency programs between January and July 2017. The survey was adapted from an existing instrument and including questions regarding knowledge of hormone therapy and other menopause management strategies available and the type of training in menopause medicine and demographic information. Of the 703 surveys sent, a total of 183 residents representing 20 U.S. residency programs responded, with a response rate of 26%. 77% of trainees were between 26 and 30 years of age, 66% were female, and 94% believed that it was important or very important to be trained to manage menopause. Although most respondents answered some of the menopause competency questions correctly, important gaps were identified. For example, 34% of the participants indicated that they would not offer hormone therapy to a symptomatic, newly menopausal woman without contraindications, and only 39% of the participants indicated that they would prescribe hormone therapy to a prematurely menopausal woman until the natural age of menopause. Of 177 respondents, 20% reported not receiving any menopause lectures during their residency, and only 7% reported feeling adequately prepared to manage women experiencing menopause. That a substantial number of the participants indicated that they would not offer hormone therapy to a symptomatic, newly menopausal woman without contraindications, and that they would not prescribe hormone therapy to a prematurely menopausal woman until the natural age of menopause, is especially telling of the gaps in the current knowledge of residents in training. Specifically, while the Women's Health Initiative hormone therapy results, published in 2002, raised concerns regarding the risks of cardiovascular disease and breast cancer with hormone therapy, subsequent analyses demonstrate quite clearly that hormone therapy is appropriate and safe for symptom relief in younger, recently menopausal women without contraindications, and that the risks identified in the Women's Health Initiative trials apply primarily to women who initiated hormone therapy after age 60 years and more than a decade after menopause. Indeed, numerous organizations across disciplines have issued guidelines supporting the use of hormone therapy in symptomatic women early in menopause. The findings in the present study of Kling et al. Thus demonstrate that such guidelines regarding menopause management, broadly endorsed by numerous organizations, are insufficiently appreciated by residents in training. The authors conclude that trainees in residencies in family medicine, internal medicine, and obstetrics and gynecology recognize the importance of training in menopause management, but important knowledge gaps exist. Specifically, didactic education should encompass, among others, such topics as awareness and recognition of menopausal symptoms, risks and benefits of hormone therapy, alternatives to hormone therapy for symptom relief, hormone therapy in the setting of premature menopause, and selection of appropriate candidates for hormone therapy. Additionally, clinical rotations focusing on menopause management should be implemented where feasible. Investing in the education of future clinicians to provide evidence-based, comprehensive menopause management for the growing population of midlife women is thus a high priority. This article is accompanied by an editorial entitled Barriers to the Care of Menopausal Women, and it is authored by Dr. Sarah Berger from the Utah Center for Reproductive Medicine in Salt Lake City and Dr. Vesna Garovic from Mayo Clinic in Rochester, Minnesota. These editorialists underscore the importance of appropriate menopause management in clinical practice and the need for residents to be appropriately trained in this field, and they clearly identify the challenges and barriers that currently exist and need to be addressed in such training. Our first highlight is an original article entitled Predictors of Symptomatic Kidney Stone Recurrence After the First and Subsequent Episodes, and it is authored by Dr. Lisa Vaughan and colleagues from Mayo Clinic in Rochester, Minnesota, and Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire. Symptomatic stone recurrence can vary substantially among patients, with some patients having only an isolated episode, while others having frequent recurrence attended by chronic pain and the need for repeated interventions. There are dietary modifications and medications that can be used to prevent kidney stone formation and growth, but these preventative strategies can be burdensome and costly and may have adverse effects. Identifying patients with a low or high risk of symptomatic recurrence may inform decisions regarding a lifetime commitment to interventions intended to prevent kidney stones. The authors of the present study previously developed the recurrence of kidney stone, so-called ROCS model, to predict the risk of a second symptomatic kidney stone episode after the first episode on the basis of 11 predictors. However, this tool is not applicable for predicting the recurrence in those who've had 2 or more symptomatic episodes. The relationship between the number of previous stone episodes and the risk of symptomatic recurrence is unclear in the general community. There is some evidence that more past stone episodes predict an increased risk of future episodes. However, such evidence has been derived from subspecialty clinics. The purpose of the present study was to predict symptomatic recurrence among community stone formers with 1 or more previous stone episodes. The analysis involved a random sample of incident symptomatic kidney stone formers in Olmsted County, Minnesota, who were followed for all symptomatic stone episodes resulting in clinical care from January 1984 through January 2017. Clinical and radiographic characteristics at each stone episode predictive of subsequent episodes were identified. In this study, there were 3,364 incident kidney stone formers with 4,951 episodes. The stone recurrence rates per 100 person-years were 3.4 after the first episode, 7.1 after the second, 12.1 after the third, and 17.6 after the fourth or higher episode. A parsimonious model identified the following independent risk factors for recurrence: younger age, male sex, higher body mass index, family history of stones, pregnancy, incident asymptomatic stone on imaging before the first episode, suspected stone episode before the first episode, history of a brushite, struvite, or uric acid stone, no history of calcium oxalate monohydrate stone, kidney, pelvic, or lower pole stone on imaging, no uterovesical junction stone on imaging, number of kidney stones on imaging, and diameter of the largest kidney stone on imaging. The model had a C index corrected for optimism of 0.681 and was used to develop a prediction tool. The risk of recurrence in 5 years ranged from 1% to 94% depending upon risk factors, the number of past episodes, and years since the last episode. The authors conclude that the revised recurrence of kidney stone tool predicts the risk of symptomatic recurrence by using readily available clinical characteristics of stone formers. This prediction tool for estimating recurrence can be used to guide the management of stone formers by individualizing prevention intervention on the basis of the risk of symptomatic recurrence. The tool can also be used to estimate symptomatic stone episode rates that result in clinical care for clinical trials on kidney stone prevention. The second highlight is an original article entitled Wide Variation in Opioid Prescribing After Urological Surgery in Tertiary Care Centers. The study is authored by Dr. Matthew Ziegelman from Mayo Clinic in Rochester, Minnesota, and colleagues from Mayo Clinic in Scottsdale, Arizona, and Jacksonville, Florida. The United States is facing an opioid epidemic. In 2015, for example, it was estimated that 92 million Americans use prescription opioids, including 11.5 million who misuse them. Opioid overdose deaths have tripled between 1999 and 2016, exceeding 42,000 deaths in 2016. 40% of these deaths involve prescription opioid. Many patients who misuse prescription opioids obtain the drug through diversion of a prescription medication, commonly from an acquaintance or a family member. Opioids are widely used in the management of acute postoperative pain. There is an emerging view that strict standards in prescribing opioids for the management of acute postoperative pain may reduce opioid abuse. For example, the state of Minnesota convened a work group that released guidelines which limit postoperative opioid prescriptions to less than 7 days and or less than 200 oral morphine equivalents. Relevant to such strategies and others intended to appropriately limit the use of opioids is the need for up-to-date and accurate analyses of institutional and departmental prescribing patterns. The purpose of the present study was to describe postoperative opioid prescribing practices in a large cohort of patients undergoing urological surgery. The authors identified 11,829 patients who underwent 21 urological surgical procedures at 3 associated facilities from January 2015 through December 2016. After converting opioids to oral morphine equivalents, prescribing patterns were compared within and across procedures. Subgroup analysis for opioid-naive patients, that is, those without a history of long-term opioid use, was performed. Statistical analyses was utilized to evaluate variations based on demographic and perioperative and postoperative variables. The data demonstrate that of the 11,829 patients, 78% were prescribed an opioid at discharge, and the median oral morphine equivalents prescribed was 188. Of the total cohort, 9,253 patients, 78.2% were considered opioid naive. Striking variation in prescribing patterns was observed within and across surgical procedures. For example, interquartile ranges of 150 or greater were observed for open cystectomy, open radical nephrectomy, retroperitoneal node dissection, hand-assisted laparoscopic nephrectomy, and penile prosthesis. On multivariate analysis, younger age, cancer diagnosis, and inpatient hospitalization were associated with a higher likelihood of receiving a highest quartile oral morphine equivalent prescription for opioid-naive patients. 30-day refill rates varied from 1.6% to 25.9%. Refill rates were high in patients receiving more opioids at the time of discharge. The authors conclude that considerable variation in opioid prescribing patterns exists within and across surgical procedures. These data provide support for the development of standardized opioid prescribing guidelines for postoperative analgesia as one way of addressing the opioid epidemic, especially as it applies to the postoperative setting. The third highlight is a brief report entitled Amantadine Use for Postoperative Concussion, and it is authored by Dr. Ivan Karabenchioff and colleagues from Mayo Clinic in Rochester, Minnesota. The development of post-concussion syndrome following traumatic brain injury can result in a wide range of potentially debilitating symptoms that include headaches, cognitive dysfunction, and mood disorders. There are quite limited data regarding medications that may be beneficial in this setting, especially regarding the treatment of persistent headaches attributed to trauma. In current clinical practice, medications such as amitriptyline, nortriptyline, topiramate are commonly used as first-line therapies. Amantadine has been used to treat a variety of symptoms in the setting of traumatic brain injury, ranging from aspects of frontal lobe disorders to increasing the rate of functional recovery. In occasional cases, the authors of the present study have observed that amantadine has been anecdotally helpful for post-traumatic headaches. The present study examined the effect of amantadine on post-traumatic headaches. The analysis involved a retrospective medical record review of data collected from patients with a diagnosis of post-concussion syndrome in the neurology and physical medicine and rehabilitation outpatient clinics to evaluate the response of post-concussive symptoms to amantadine. A complete trial of amantadine was defined as 100 milligrams twice per day for 2 months. 33 patients were prescribed amantadine for post-concussive syndrome following traumatic brain injury. 1/3 of patients discontinued the medication due to side effects. However, post-traumatic headaches were improved in 80% of patients that completed a full trial of amantadine. Surprisingly, patients reported improvement in headaches even if the medication was prescribed years after the initial trauma. Little improvement was noted in other symptoms such as poor memory, dizziness, and personality changes. Although significant additional research is certainly needed, amantadine may be a reasonable medication to consider for the treatment of persistent headaches attributed to trauma, even if the initial injury is remote. You can access these highlights and editor's choice articles free of charge during the entire month of February. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons on the top of the home page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you will find author interviews, 60 seconds video article summaries, and our Mayo Clinic Proceedings fireside chat recordings, which are available from our website on the home page, as well as through iTunes. You'll also find our Pioneers and Legends video interviews currently featuring Dr. Nanette Wenger, Distinguished Professor from Emory University in Atlanta, Georgia. On our website, you'll see many news stories that are based on articles published in Mayo Clinic Proceedings, And finally, you will see other free content and articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.